Good afternoon, everybody. I'm Alan Kleiger, clinical professor of medicine at Yale University School of Medicine, and also the chair of the American Society of Nephrologists Transforming Dialysis Safety Initiative. We're really delighted that this webinar is being brought to you through a national partnership between the Centers for Disease Control and Prevention, the CDC, and the American Society of Nephrology, the ASN. During today's presentation, Dr. Erica D'Agata and Ms. Nicole Gualandi will discuss the management of C-DIFF in outpatient hemodialysis settings. The goal of this webinar is to provide an overview on the importance of identifying and tracking possible Clostridioides Difficile infections, or as we'll be saying from now on, CDI, in the outpatient dialysis setting, as well as suggestions for decreasing potential transmission of CDI within the dialysis facility. Here is our agenda. Our webinar will include 2 interactive polling questions between presentations and conclude with a question and answer session based on the questions that you, the audience, submitted during the registration process and provided in the chat function throughout today's webinar. Please note a few housekeeping items related to resources from this webinar. The webinar is being recorded, and following today's webinar, the recording, slides, and speaker bio handouts will be posted on the ASN NTDS website. Finally, in acknowledgement of the changing nature of medical information in practice, particularly during a pandemic, please note the disclaimer on this slide. Okay, so let's go to the first polling question. So this is your chance to participate. So the question here is, does your facility have a policy and procedure for management of Clostridioides difficile infections in your dialysis facility? Please select yes or no, or you don't know. Please vote now. All right, well, you see here that over 50% of you do know that you have a policy, but interestingly enough, nearly a third don't, or another 10–15% don't know if there's a policy. I think this is important because you'll have the opportunity to go back to your facilities and talk about what your policy is and to clarify for you and the whole staff what that policy needs to be. Okay, well, first on deck is Dr. Erica D'Agata. It's my real pleasure to introduce her. Dr. D'Agata is a professor of medicine at the Warren Alpert Medical School at Brown University and is the director of research for the Division of Infectious Diseases at Rhode Island and Miriam Hospitals. Her clinical research focuses on the clinical and molecular epidemiology of multi-drug resistant organisms in a variety of healthcare settings, including the outpatient hemodialysis unit, long-term care facilities, and hospitals. Erica.
Good morning, everyone. I have no disclosures. So the morbidity and mortality associated with C. difficile infections is quite alarming. C. diff infections can cause up to 29,000 deaths per year in the US, and about 20% of patients can also have a recurrent C. diff infection. They'll have a prolonged hospital stay, and there's excess hospital costs associated with these infections. And this is in the general population. C. diff is the most common cause of gastroenteritis-related deaths. In 2017, C. diff was responsible for almost 500,000 infections and over 20,000 deaths. And it's one of the most common hospital-acquired infections. And lastly, ongoing spread within the community setting can account for up to 42% of all C. diff infections, which has implications for the dialysis unit. What are the risk factors for C. diff? And this is in the general population. Antimicrobial exposure is the main risk factor. Advanced age, as well as comorbidities, including requirement for maintenance hemodialysis. And lastly, residing in a nursing home setting. How is C. diff transmitted? Well, the transmission dynamics of C. diff are very similar to multi-drug resistant organisms such as MRSA and VRE. So if you look at this box, which represents the hospital setting, C-DIFF and MDROs can be transmitted between patients through the hands of the healthcare workers or inanimate surfaces that are contaminated. As well, patients can leave the hospital into the community and they can acquire C-DIFF or MDROs there. And you can think of this as the dialysis setting as well. The main difference between the transmission dynamics of MRSA and VRE compared to C-DIFF is that C-DIFF produces spores. And these spores survive for over several months on inanimate surfaces. And so it has implications for increased transmission from contaminated surfaces. As well, these spores are resistant to commonly used disinfectants that usually target MDRO eradication. The other issue that's very important to emphasize about the spores is that soap and water removes the spores and kills them, but alcohol-based sanitizers do not effectively eliminate the spores. However, having said this, in the hospital setting, where alcohol-based sanitizers are the main form of hand hygiene, increased rates of C-DIFF have not been seen, suggesting that alcohol-based sanitizers are sufficient. And we all know that there's greater compliance with alcohol-based sanitizers versus soap and water, which takes a lot longer. And so alcohol-based sanitizers, based on these issues that I just mentioned, are considered an alternate hand hygiene measure to prevent C-DIFF. However, it's important to note that since the sanitizers don't eliminate the spores, soap and water is always preferred. And in an outbreak setting, you should always use soap and water. And how do you define an outbreak setting? Well, it's really any increase in C-DIFF above your baseline. So if you have one patient who was recently transferred back to your unit with C-DIFF, and the next week you see a second patient with C-DIFF, that should start to raise an alarm, and you should consider that maybe you're starting to see spread and a potential outbreak. And the advice is always to call your local public health department that can help out. Again, with the spores, you have to use specific disinfectants that are approved to be effective against C. difficile spores, and they're the List K agents, which can be accessed at this website. So now talking specifically about patients who require maintenance hemodialysis, MHD. These patients are 2 to 2.5 times more likely to develop C-DIFF compared to patients who are not on MHD. Mortality rates among MHD patients with C-DIFF are twofold higher than those without C-DIFF. And from 2004-2013, hospitalization rates from C-DIFF among MHD patients increased by 68%, a startling percentage. And the lengths of hospitalization related to C-DIFF are much longer for MHD patients compared to the general population. So what are the risk factors specific to people on maintenance hemodialysis with C-DIFF? Again, it's antimicrobial exposure. Studies have shown that independent risk factors are low albumin as well as a high Charlson comorbidity score. So the more number of comorbidities the patient has, the more likely they are to get C-DIFF. So it can include malignancies or diabetes, etc. I'm going to speak a bit more about the antimicrobial aspect because it's the most common risk factor for C-DIFF. The three most common antimicrobial used in outpatient dialysis units are vancomycin, followed by cefazolin, and third and fourth generation cephalosporins like ceftriaxone or cefepime. And we know from several studies that about 30% of doses prescribed in the outpatient dialysis setting are not indicated, and this is based on national guidelines. And the most commonly inappropriately prescribed antimicrobials, number one is vancomycin, but a close second are the third and fourth generation cephalosporins, and then at 13% cefazolin. So what are the reasons for inappropriate administration of these antimicrobial doses? This was a study looking at over 900 doses administered in outpatient dialysis units. The most common reason for inappropriate prescribing, so again, not meeting the national guidelines, was that the criteria for infection was not met. And the most common infection was presumed bloodstream infection. So in fact, the patient had a contaminant, not a true bloodstream infection. So the classic single positive blood culture for coagulase negative staph in an afebrile and otherwise hemodynamically stable patient. And SSTI, so skin and soft tissue infections that do not meet the Infectious Disease Society of America criteria. The second main category of inappropriate prescribing was that a more narrow spectrum of antimicrobial was not chosen for continuing doses, so not the empiric ones. And this was vancomycin. So the classic scenario is you have somebody who you know has a Staph aureus bacteremia, they're started on vancomycin, and then the antimicrobial susceptibility profile comes back and the Staph aureus is methicillin susceptible. So the patient should not remain on vancomycin, but instead be de-escalated to cefazolin or nafcillin, unless there's allergies. As well, third, fourth generation cephalosporins, the scenario is somebody with an E. coli bacteremia, they're empirically started on ceftriaxone or cefepime. The susceptibility data comes back and the E. coli is susceptible to ANSIP, but the patient remains on third or fourth generation cephalosporins. So what are the clinical and economic benefits of implementing an ASP, so antimicrobial stewardship program in outpatient dialysis facilities? We looked into this by generating a decision analytical model that looked at total antimicrobial use and the effectiveness of a stewardship program, rates of VRE, MRSA, multi-drug resistant gram-negatives and C-DIFF, and infection-related mortality, and lastly, costs. So on a nationwide level, this model showed that implementing an ASP, which decreased inappropriate antimicrobial prescribing by 20%, resulted in a 4.8% reduction in MDROs and C. diff infections, a 4.6% reduction in infection-related deaths, and 5% reduction in costs. And this figure summarizes the model where, as I mentioned, the effectiveness at 20%, the yellow bars reflect the decreased infection or preventing infections, the blue bars preventing mortality, and the black line incremental cost savings. You can see that as you increase the effectiveness of the antimicrobial stewardship program, you have a dramatic effect on preventing infections, mortality, and costs. So again, emphasizing the importance of having an antimicrobial stewardship program in your unit. We performed a prospective study where we actually implemented a targeted stewardship program in 6 dialysis units in the Boston area. It was based on educational and behavioral interventions. And we showed that there was a 6% monthly reduction in antimicrobial prescribing per 100 patient months. The main reasons was that we were able to decrease vancomycin to cefazolin, the de-escalating issue when the patient has methicillin susceptible Staph aureus. We increased the discontinuation of antimicrobials when criteria for infection was not met as well. And it's important to point out that there were no adverse consequences to implementing the stewardship program. So for example, there were no increases in rates of bloodstream infections or hospitalizations. So I discussed the impact on morbidity and mortality on our patients who require maintenance hemodialysis. And we wanted to provide practical strategies and guidance for managing C. diff in the outpatient dialysis facilities. What can you do when your patient comes back from the hospital with a diagnosis of C. diff? What can the healthcare workers do to prevent C. diff spreading in your unit? And the suggestions or recommendations are directed at adult outpatient dialysis facilities. And as with any recommendations, they should not substitute for individual clinical judgment. Our author panel was composed of nephrologists and infectious disease physicians, clinical nephrology nurse specialists, clinical managers of dialysis facilities, public health experts, and infection preventionists. And this is our author panel, and the full paper can be found in Kidney International, published recently. So what are these suggestions? Number one, what are the infection prevention and control resources activities that one should implement in your outpatient unit to prevent the spread of C. diff and care for the patient with C. diff? So what do you do when the patient needs to come back to your unit, but in the hospital they acquired C. diff and you have to accept them back? And so what can you do to prevent transmission of C. diff? So you should develop and maintain a robust IPC program that is integrated in your CAPI program. You should assure that at least one individual with training in IPC is regularly available to the facility. And this is similar to implementing a stewardship program where you want to identify the champion who's going to lead this IPC implementation to prevent C. diff. You should have written policies detailing these IPC precautions specifically designed to prevent the transmission of C. diff. Education and training should be provided to all healthcare workers on the basic principles and practices for preventing the spread of C. diff. And there's numerous review articles in the literature addressing specifically the nephrology community and patients. You should also educate your patients about C. diff and what they can do when they come into the unit and they have diarrhea, how to prevent it, and I will go into more detail about this. You should conduct regular surveillance for C. diff, calculate your rates, and share the results with the frontline clinical staff. And it's important to have facility rates because, as I mentioned before, this is how you know if there's a potential outbreak that's going to happen, because your baseline rate goes up. You should encourage judicious use of antimicrobials, as I mentioned before. Ensure open communication with other healthcare facilities. So in other words, during the transfer of a patient, either from the hospital back to the unit, there should be communication. Or if you have a patient in the unit that goes to a nursing home, for example, there should be open communication that this patient has C. diff and diarrhea. And lastly, you should contact your local or state health department if an outbreak or a cluster is detected, or if transmission is identified within the facility. So again, if you have one patient 1 week and the next week you see 2 patients, this should raise an alarm that there may be some cross-transmission within your unit. Number 2, what are the preferred hand hygiene measures when caring for a patient with C. diff? As I mentioned, it's the issue of hand sanitizers versus soap and water. As always, and with any MDRO and in general, wear gloves when caring for patients with C. diff to reduce hand contamination. Perform hand hygiene before donning gloves and when you remove them. And as I mentioned, soap and water is preferred, but alcohol-based hand rubs are acceptable because of the improved compliance with this hand hygiene measure. But if there is an outbreak or concern for patient-to-patient transmission within the facilities, then you should really implement soap and water and not use hand sanitizers. So perform hand washing with soap and water if there's direct contact with feces or an area with fecal contamination is likely. Encourage patients to perform hand hygiene and increase their personal hygiene measures before they come to the dialysis session. This will decrease the amount of spores they have on their skin that can subsequently contaminate the dialysis chairs and other parts of the environment. And lastly, audit the healthcare workers' hand hygiene compliance and provide feedback. Number 3, what personal protective equipment, PPE, should be worn when caring for a patient with suspected or confirmed C. diff. You should always wear gloves and remove them immediately and discard them when finished taking care of the patient. Always wear a new gown over the clothing during high contact patient care activities. And these refer to starting and stopping dialysis, accessing their vascular access, or when you help them sit in their station or leave their station. Use disposable face shields for each interaction that warrants face protection. And then remove your PPE slowly and deliberately, carefully in a sequence that prevents self-contamination. Again, similar principles to MDRO, preventing transmission of these pathogens. Number 4, what is the preferred placement of patients with C. diff? Assess your patient for signs and symptoms of C. diff prior to entry in the treatment area. Provide dialysis during sessions with the fewest number of other patients or minimal number of adjacent stations as possible. Again, this will decrease the likelihood that your patient with C. diff will be spreading it to other patients. If there's less people beside him or her, then there's going to be less likelihood of transmission to another patient. Consider using isolation rooms like the hepatitis B room if you have no hepatitis B infected patients being cared for in the facility. And once the patient with C. diff is dialyzed in the hepatitis B room, it has to be terminally cleaned with, again, the List K environmental disinfectants. And lastly, the dialysis station or isolation room, again, should be thoroughly cleaned with the C. diff active disinfectants. Number 5, what bathroom facilities should be provided to your patient with C. diff? First of all, bathroom facilities should be thoroughly cleaned with C. diff approved disinfectants after use by a patient who has C. diff. Assess the patient before he or she enters the treatment room to determine if they have active diarrhea or incontinence. Limit the use of bedpans and bedside commodes in the treatment floor. if at all possible, because they just provide a higher likelihood of transmitting spores just because of the use of bedpans and bedsides that can touch other inanimate surfaces and contaminate yourself, the healthcare worker. For privacy, you can use rollout screens if you're using bedpans or commodes, and they should be non-porous and immediately cleaned and disinfected with C-DIFF approved disinfectants after use. Lastly, change and discard all the PPEs and perform hand hygiene with soap and water immediately after assisting the patient with toileting activities. Number 6, what's the appropriate time of maintaining precautions? C-DIFF precautions should be continued for at least 48 hours after the diarrhea has stopped. If C-DIFF symptoms recur after precautions have been discontinued, then C-DIFF specific precautions, as I've mentioned, should be resumed. And lastly, C-DIFF precautions beyond 48 hours should be considered if the rates of C-DIFF in your unit remain high, despite implementing these prevention strategies. And number 7, what are the optimal measures for environmental disinfection? Again, you should thoroughly clean and disinfect your station with the List K agents provided on that link. You should limit multi-use items and dedicate patient care items that are typically multi-use to the care of the patient with C-DIFF. Again, just to prevent transmission of spores to other patients through these items if they become contaminated. And lastly, you should audit staff practices to ensure effective environmental disinfection is occurring, and again, providing feedback. So in summary, these recommendations follow the same principles outlined by the Centers for Disease Control, Society of Healthcare Epidemiology of America, and Infectious Disease Society of America in preventing C-DIFF, but they've been tailored to the unique setting of dialysis facilities. And as always, we need further research to better understand the C-DIFF transmission dynamics and most effective strategies to implement in our outpatient dialysis unit. And I'm going to finish by discussing an outbreak that occurred in an outpatient unit in Michigan, where 8 out of 37 patients, so almost 22%, developed C-DIFF from October 2012 to March 2013. And also important to emphasize is that 1 healthcare worker developed C-DIFF. So this is not just preventing C-DIFF amongst our patients, but also for the healthcare workers that are taking care of these patients. They are, at high risk of acquiring C-DIFF from them as well. And the reasons for this outbreak that were found was that there was inadequate hand hygiene, insufficient wet contact times of bleach on surfaces, and patients without C-DIFF were being dialyzed at designated C-DIFF only stations. So all these things that were identified increased the likelihood that C-DIFF was being transmitted. So the following implementation of control measures occurred and the outbreak stopped. So there were designated 3 dialysis stations only for C-DIFF patients, donning gloves and isolation gowns, soap and water for hand hygiene, and lastly, a 1 in 10 dilution of bleach to disinfect dialysis stations. And these were all effective in terminating the outbreak. Thank you.
Thanks, Erica. Comprehensive and really helpful. So it's time for our second polling question. So here's your turn to participate here. Do you include the results of monitoring for CDI in your facility's quality assessment performance improvement meetings, the QAPI meetings? Yes, no, or you don't know? Please answer now. Okay, can we see the results? Oh, really interesting. So yes for 1/4 of the audience, and no or unknown for 3/4 of the audience. So here again, something that may be important to go back and talk to your unit about. It's my real pleasure to introduce Nicole Gualandi. Ms. Gualandi is a nurse consultant with CDC's Prevention and Response Branch of the Division of Healthcare Quality and Promotion. And she's worked at the CDC for about 8 years. Her current work includes coordination of dialysis infection prevention projects and consultation on dialysis outbreaks. Nicole.
Thank you, Dr. Klauger, and thank you, Dr. D'Agata, for that great introduction. I have no disclosures. So now we're going to walk through two case scenarios. The first scenario, we'll walk through a patient treatment where the recommended infection prevention practices just discussed are not implemented, putting patients and staff at risk for transmission of C-DIFF in the facility. So as we go through the first scenario, see if you can catch any practices that could be changed to decrease the risk of transmission, and I'll point out a few at the end. The second scenario is very similar, but it will walk through a patient treatment where the recommended infection prevention practices are implemented, which decrease the risk of C-diff transmission within the facility. And please note, these scenarios do not discuss the treatment of C. difficile. So let's start with the first case scenario. Mrs. A arrives for treatment at her normally scheduled time on Monday morning. After performing her COVID-19 screening in the waiting room, she comes to the treatment area, stopping at the scale, and then washes her access arm in the designated sink. Then she gets settled in her chair. Mrs. A was diagnosed with C. difficile a month ago, but has not reported any symptoms since resolution of the infection 2 weeks ago. After the technician gathers supplies and assesses Mrs. A's fistula, she performs cannulation and connection to the machine per usual practice. When the technician is gathering up all the used supplies for disposal, Mrs. A tells her that she fears she may have C. diff again because she has not been feeling well the past few days and has had nausea and lots of diarrhea, just like when she tested positive before. She does not think she has COVID-19, so answered no to all the screening questions when she arrived. The tech cleans her hands thoroughly with alcohol hand gel when leaving the station and heads to discuss Mrs. A's symptoms with the charge nurse. The charge nurse receives an order to test a stool specimen for C. diff from the nephrologist and talks with Mrs. A about how to collect the sample the next time she uses the restroom. Everything is running smoothly until about halfway through treatment when Mrs. A informs the tech that she needs to urgently use the restroom. The tech brings over the portable commode and cloth screen barrier, uses hand gel, puts on new gloves, and disconnects Mrs. A from her machine. Mrs. A has some trouble moving from the chair to the commode, so the technician assists her and helps her get settled on the commode. Just as Mrs. A is comfortable, a machine alarms at another station in the tech's treatment area. The tech, knowing everyone is very busy, doesn't want to call someone from another area to assist, so she quickly goes over and silences the machine without removing her PPE. After silencing the machine, she removes her gloves, performs hand hygiene using alcohol gel, puts on the new clean pair of gloves, and goes back to check on Mrs. A. After a couple more minutes, Mrs. A lets the tech know she's done, so the tech assists her, getting back to her treatment chair, and reconnects Mrs. A to the machine and starts her treatment back up. After restarting the treatment, the tech obtains a stool sample from the commode, carrying the filled sample container to the laboratory area. Once that's done, the tech carries the removable portion of the commode to the dirty utility room, which is located at the back of the unit, to discard in the hopper. She returns to find that one of her coworkers has helped out by putting the barrier screen and the commode away. So she carefully removes and disposes of her gloves and cleans her hands with alcohol gel. The tech does not change her gown. The technician wonders to herself if the person who helped actually cleaned and disinfected the commode and screen before they put it away. But because she is now running behind, she does not have time to follow up with that person, and there's another machine alarming that she needs to answer. When Mrs. A's treatment is finished and her standing blood pressure is stable, she heads back to the scale. Mrs. A lets the tech know her weight and sits down in a common use wheelchair to wait. This is usual practice for her, as the treatments leave her feeling tired. Mrs. A independently wheels herself out of the treatment area, pushing the automatic door button to get to the waiting room. Her significant other is waiting, and they exit the building. Another patient sees her leaving and asks if he can use the wheelchair if she's done with it. Mrs. A's significant other says sure and pushes it over when Mrs. A is safely in the car. Back in the treatment area, the tech does not see any blood or body fluid contamination at Mrs. A's station, so she performs routine station disinfection and gets ready for her second shift patient. On Wednesday, when preparing for Mrs. A's treatment, the tech prepares Mrs. A's normal station. No specific C. diff precautions are implemented. Mrs. A's treatment is uneventful, and when she's stable, she exits the clinic per her usual practice. So in this scenario, a lot of potential contamination events occurred, which put the facility at risk for transmission of C. diff. Without proper infection prevention practices and environmental cleaning, the C. diff spore can easily contaminate the environment and potentially be transmitted to other patients and staff, just like Dr. Adagata outlined before. Some of the contamination events that occurred in this scenario include those high-touch surfaces were contaminated by potentially dirty hands, such as the scale, those door handles, or the door buttons. The tech wore the same gown, even after helping with those high-contact activities, the fecal specimen collection, and cleaning of the commode. The tech wore contaminated gloves and didn't change them when silencing a machine alarm at another station. The technician was unsure if the commode and the privacy screen were appropriately cleaned and disinfected when they were put away. That common use wheelchair was not cleaned and disinfected before it was used by another patient. And when the patient came back on Wednesday, there was improper patient placement on Wednesday's treatment because the patient had had active diarrhea less than 48 hours prior. So now let's walk through a case scenario that uses the CDI infection prevention recommendations to keep patients and staff safe. Mr. B arrives for treatment at his normally scheduled time on Monday morning. He was diagnosed with C. difficile a month ago, but has not reported any symptoms since resolution of the infection 2 weeks ago. After performing his COVID-19 screening, Mr. B waits in the waiting room. When the technician comes out to bring Mr. B back for his treatment, he asks if there have been any health issues to report. Mr. B tells the tech he fears he may have C. diff again because he's not been feeling well the past few days and has had nausea and a lot of diarrhea, just like when he tested positive before. He does not think he has COVID-19, so answered no to all the screening questions when he arrived. The tech asks a few more targeted questions about symptoms and then asks Mr. B to wait a bit longer so he can talk with the charge nurse and potentially set up a different machine. After discussing with the charge nurse and determining the symptoms are related to Mr. B's history of C. diff and not COVID-19, the tech sets up Mr. B's treatment in a new station with the fewest number of adjacent stations possible to reduce risk of exposure to other dialysis patients in the facility. The tech also asks another staff member to clean and disinfect the high-touch surfaces and chair in the waiting area once Mr. B is brought back for his treatment. The tech performs hand hygiene with alcohol hand gel and puts on clean gloves to escort Mr. B into the treatment area. After stopping at the scale and sink to wash his access, Mr. B gets settled in his chair. The tech goes back to clean and disinfect the scale buttons and sink handles with an appropriate disinfectant. Next, the tech performs hand hygiene with alcohol hand gel and puts on a new clean gown, gloves, and eye protection. The tech performs cannulation and connects Mr. B to the machine per usual practice. When he's done, he removes his PPE slowly and deliberately prior to exiting the patient station and performs hand hygiene with alcohol hand gel. The charge nurse who received the order for a stool culture talks with Mr. B about how to collect the sample and provides the proper supplies. Everything's running smoothly until about halfway through treatment when Mr. B informs the tech that he needs to urgently use the restroom. The tech performs hand hygiene with alcohol hand gel, puts on a new clean gown, gloves, and eye protection. Mr. B is disconnected from his treatment. The tech makes sure Mr. B is steady on his feet, has all the supplies needed to obtain his stool culture, and guides him to the patient restroom located within the clinic, making sure not to contaminate any surfaces along the way. The tech carefully removes his PPE and cleans his hands before doing any other work. When Mr. B returns, the tech takes the opportunity to discuss the importance of appropriate hand washing when someone is sick with C. diff, and that cleaning his hands with soap and water is the best choice after using the restroom. After cleaning his hands and putting on new PPE, the tech reconnects Mr. B to his machine and then carefully removes his PPE and performs hand hygiene. The tech places an out of order sign on the bathroom until the room can be thoroughly and appropriately cleaned. And he also cleans any items or surfaces that Mr. B may have touched within the clinic on his way to and from his treatment chair with that C-DIFF approved disinfectant. After treatment is completed, the tech carefully removes his PPE appropriately, performs hand hygiene, and puts on new clean gloves before escorting Mr. B to the scale. Mr. B typically uses a wheelchair after treatment, so the tech assists him into one of the clinic's common use wheelchairs. Before leaving the scale area, the tech wipes down any items or surfaces Mr. B touched with an approved disinfectant. The tech then wheels Mr. B into the waiting area where he meets his driver, and the tech continues to escort them both to the facility exit. The tech is approached by an incoming patient who asks to use the wheelchair. But the tech tells that incoming patient to wait, and he'll have someone else bring them a different wheelchair, as the one he's using needs to be cleaned before it can be used by someone else. Going back inside the clinic, the tech removes his gloves, performs hand hygiene, and puts on the appropriate PPE to thoroughly clean and disinfect Mr. B's used station and the wheelchair using the approved C-Difficile disinfectant. On Wednesday, when preparing for Mr. B's treatment, the tech is sure to select a station with the fewest number of adjacent stations, since it's been less than 48 hours since he had active diarrhea during his treatment on Monday. The tech and the charge nurse discuss assessing the last episode of diarrhea when Mr. B arrives to determine when precautions can be lifted according to facility policy. So listening to this case scenario, you may have been left feeling like implementing these infection prevention measures will take way too much time. But just like when you start any new activity in the dialysis unit, these activities will take more time in the beginning. But preventing the transmission of C. diff is important, so your facility may need to look into updating patient scheduling or staffing to ensure these measures are successful. So in this scenario, a lot of potential contamination events did not occur, which decreased the facility's risk for transmission of C. diff. With proper infection prevention practices and environmental cleaning, the C. diff spore cannot easily contaminate the environment, and potential transmission to other patients and staff is stopped. So some of the good infection prevention practices that occurred in this scenario include that patient was assessed prior to entering the treatment floor, ensuring that the proper station was selected for him. Those high-touch surfaces, such as the scale, the door handles, and buttons, were frequently cleaned and disinfected. The technician changed PPE after helping with those high-contact activities. The patient's privacy was maintained through use of that restroom, and the restroom contamination was limited by cleaning and disinfecting it after use by that C. diff patient. And that common use wheelchair was cleaned and disinfected before it was used by another patient.
Well, that's great. Thank you, Nicole. That was really helpful and practical. And I particularly liked your description that it seems like it takes so much to do that right. And yet once that becomes part and parcel of what each of us does, it goes easier than thinking of the onerous task of making sure to keep clean and to do all of that protection correctly. So let me ask both of our speakers to put on their webcams, please, and also your microphones. And I want to go through some of the questions that our audience has asked of us. The first is this. For years, I've been calling C. diff Clostridium difficile, and now you're calling it Clostridioides. Is there a difference?
So it's just a different name to the pathogen. It's the same pathogen, just renamed to Clostridioides based on data from 16S sequencing and changing the taxonomy of it. Okay,
so just a name change. It's the same organism that we've been dealing with all these years.
Yeah, just more difficult to spell.
Okay. One of our audience said that they think they've never seen this and wonder, do we know specifically what the incidence of C. diff is in hemodialysis and in peritoneal dialysis facilities and units?
So we have some data, not a lot, but it definitely occurs. There was a huge study based on the United States Renal Data System database of about 500,000 people, and they showed that approximately 4 to 5% of patients with end-stage renal disease had an episode of C. diff. And other large database-based studies show, anywhere from 2% to 3%. But more granular data is not available. But it definitely can occur. It's just a matter of time because your patients requiring dialysis are hospitalized very frequently. That's where they're at incredible high risk of getting C. diff, which in some hospitals keeps increasing, and then they come back to your unit. So you just have to be prepared of what to do when that happens.
Okay. So Nicole, one of our audience asks this: since C. diff so frequently comes from the hospital, should we have consideration of adding a question about GI symptoms for all patients returning to units following hospitalization or recurrent treatment with antibiotics?
It's something we didn't actually include in the paper, but it's not a bad idea. It's not something that we require, but I think, asking them about their antibiotic received while they were in the hospital, and also, that symptom onset before they come back to the unit. There's, communication between facilities can be a big problem. So if you aren't getting information from those facilities, going and asking the patient is your next best bet.
Yeah. Okay. You both talked about taking precautions and preventing spread in the dialysis unit. So one of the audience asks, should C-diff patients be dialyzed in an isolation room? Erica, you talked a little bit about this, but so many of our units have isolation rooms, usually for hepatitis patients, that are so often not being used for hepatitis patients. How concerned should we be about spread? Should we be utilizing those isolation rooms? And what is the risk of spread from patients to staff or staff to patients when patients have this infection?
So ideally, the best thing would be, just like we use in the hospital, a single room for a patient who has MRSA, if possible. The same should apply for dialysis units. So ideally, the hepatitis B single room would prevent, as much as possible, transmission to other patients. So the details I mentioned in the talk, and you can find more in the paper that's published, but if there's no other hepatitis B positive patient that needs the room, then it could be used for a C. diff positive patient. If that's not the case and you don't have that, then as I mentioned, you have to dialyze the patient with the fewest dialysis stations beside them. And regarding patient to staff transmission, it definitely happens. We know it happens with MRSA and VRE. Our healthcare workers can acquire MRSA from our patients. And as I mentioned, this can also happen with C. diff. And as the outbreak that I talked about showed that one healthcare worker, in fact, did get C. diff from a patient. They may have been on antimicrobials, for example, increasing the risk of C. diff acquisition.
So if we are using something like an isolation room, then when can we again make that room available for other patients who need isolation?
After terminal cleaning with C. diff, proper agents.
All right. Now,
You don't have to reserve for that patient's use. You can do your routine cleaning after they're done with that List K agent, and then you can, as long as it's cleaned appropriately, you can use it for another patient. It's not like hepatitis B where you have to save that room just for that patient. You can use that room once it's been cleaned for other patients.
Okay, thanks. One of the audience asks this question. According to studies, the risk of recurrence of CDI is 15 to 25% in a first episode, and this risk increases in later episodes. So should we be considering secondary prophylaxis in those patients?
So yes, and what we do in the hospital setting is that if a patient has a history of recurrent C. diff, and it's been recent, not a year ago, but let's say a month ago, and they're back in the hospital and they need antibiotics for something else, then we give them prophylaxis for preventing C. diff because they're at high risk. So the answer is yes, in certain situations.
All right. Okay, thanks. How long should a patient be isolated after treatment for C. diff is initiated? Do we need to be resampling stools for the organism? How do we think about what happens after treatment starts in terms of isolation?
So precautions are recommended to continue for 48 hours after the diarrhea has stopped. It is not recommended to test. You just base it on clinical symptoms. And the issue here is that C. diff can also be a colonizer, not really cause infection. So you're going to get some tests that come back positive, but that doesn't truly mean they have an infection from C. diff.
So Erica, in other words, if somebody who's had C. diff now is asymptomatic, diarrhea is gone, feels great, and for some reason has stool testing done, because as you know, often stool testing is done when people come to the emergency room or the hospital if they've ever had a history of C. diff before. If a hemodialysis patient is asymptomatic but then turns up with a positive stool, what do you do?
So the first thing is they should not be tested. Patients should not be tested without diarrhea. You're just confusing what's happening. So if they are tested and it comes back positive, there's no need to treat. Because again, C. diff can be a colonizer, which we don't treat. There's also the issue that C. difficile, some strains don't produce toxin, so they don't need to be treated. So there's a lot of issues. So bottom line is don't test patients who are asymptomatic. If they're asymptomatic and for some reason they get tested and are positive, they don't need to be treated.
Okay, so can I just ask again, and Nicole, I wonder about this testing business. If I hear you saying that even if someone's had C. diff in the past, but they don't have diarrhea, but have other complaints, indigestion, should we not be testing them for C. diff?
I'll echo what Dr. Daggett has been saying. Yeah, if they have C. diff, they're going to have diarrhea, in my experience, and Dr. Daggett.
Definitely.
Yeah. So, you don't need a test of cure. That we haven't done that for quite a while. We know that that's still kind of it's holding on, that folks think need that test of cure. But also, if the patient is having formed stools, you should not be testing formed stools. You should only be testing liquid stools or diarrhea stools. So no test of cure, and please don't test solid stools.
In fact, the microbiology labs, most of them will refuse testing for C. diff unless it's a soft stool, et cetera, or loose.
Good. Okay, so I think you guys have made that point, and that's really helpful. Thank you. There were several questions about surface disinfection, and I know you referred to this K list, but let me just ask you to help us understand a little bit more. There are several alternative ways to disinfect. What is the essential element that kills these spores? What's in these agents that are used? And one question came about alternative treatments in countries that have few resources or few economic resources. How should they be thinking about disinfection? Well,
I'm not a chemist, so I don't know exactly what is in those products that they get approved. But looking at that list, there's a lot of bleach agents on that list. So most likely what they're using is probably on that list the time. But as far as cleaning, you can, as long as there's no surface contamination, so there's no visible soil, you can do your routine cleaning with those List K agents. If there is visible soil, then you have to add that cleaning step before you do the disinfecting step. That I pitch on our website, the CDC website. You can Google CDC dialysis audit tools. We have an audit tool that goes through the steps of routine station disinfection, and you can use those steps with a C. diff patient as well, as long as you're using the appropriate disinfecting agent. And follow the manufacturer's recommendations on those List K agents, because they can differ from different manufacturers. So always look at the label and see what the timing is on those things. As far as the international countries, I would suggest they email that question to CDC, because we have an international group that works specifically with certain countries, and they would be able to answer that a little bit better than I tend to only on the domestic side. So if they could email that to dialysiscoalition@cdc.gov, we can answer that or forward it to the right folks.
Right. Thank you, Nicole. That is helpful. We have a question about a dialysis unit located within a nursing facility, and you had mentioned that nursing facilities are particularly prone to C. diff and C. diff spread. So the question was, can C. diff patients be dialyzed in the same room with non-C. diff in the nursing home dialysis setting? That's usually, in this case, a 2 to 3 bed pod.
Well, I would say ideally, but that's in a real, ideal world. So if at all possible, the answer is no. If you can't, then they have to be dialyzed in the same room and be extremely vigilant on disinfection and precautions.
Yeah, and if I can add, I've visited some of these units that are within nursing homes, and I will say, if you've seen one, you've seen one. They're all completely different. And this paper that we're kind of talking about is the focus of it is not these units. The paper was focused more on the traditional outpatient setting, right? So there's a lot of other concerns in these nursing home units. They tend to be much smaller. The staff tend to be nursing home staff trained by a dialysis facility, so they're not folks that are typically they do it every day in the nursing home, but not in they're trained by someone else. So I would suggest if they have that situation, they contact their local public health for some help, or they can also email us at that Dialysis Coalition email box. And because there's so many other things to consider there, and it's not just a yes/no answer, but also saying what Dr. Agadig said, I would err on the side of probably it wouldn't be okay.
Okay, again, thank you. There's a question about waiting rooms here. What are the specific actions that should be taken to prevent spread while patients may be sitting in the waiting area?
I can start, and then Nicole, please add. I think it's a good idea to screen your patients, make sure they don't have diarrhea, and that is mentioned in the paper, because obviously that should raise a red flag. We should have hand hygiene stations all over the place, easily accessible. There has to be education to patients of proper hygiene when they come in, especially if they have diarrhea. Those would be the main things. And if somebody comes in with diarrhea and you know that they have C. diff, they shouldn't be sitting in the waiting room. They should be brought in right away to the treatment station. Those are some general suggestions. And Nicole, what else do you think?
Yeah, no, I totally agree that, and the education of patients piece is pretty integral here, I think, as well. If they can call you and tell you ahead of time that they're having active diarrhea, maybe they can. I think we've done this with some of the protocols nowadays. Within the last year, you can have them wait in their car, call them when they're ready, bring them in, decrease the contamination. And I will add, we're going into cold and flu season, right? So, facilities can implement policies to routinely clean the waiting room, on a regular basis, not just, at the end of the day or so. Some other things to consider as well to decrease that contamination.
Yeah, thank you. So the important thing I heard you say is that if a patient's had C. diff or has diarrhea, that you need to probably bypass the waiting room and not have people sit in the waiting room, but bring them directly in and isolate them in the usual way we do for people with possible C. diff. Is that correct?
Yes.
Okay, all right.
One of them, but an important one.
So a related question to the diagnosis of people you think as outpatients might have this. The diagnosis of outpatient C. diff takes time. So should we have a policy for hand washing rather than alcohol gel for each patient that has diarrhea?
But as we mentioned, hand hygiene is the gold standard. So ideally, again, in a real ideal world, everybody should be using soap and water in the units. That's not logistically feasible and compliance is low. So that's why hand sanitizers are an alternative. So those are the principles I would use.
Okay. Thank you. Has the incidence of C-DIFF decreased since COVID-19 hand washing and distancing and personal protective equipment? It's become so ubiquitous now. Has the incidence of Clostridioides difficile decreased since this era?
There's some studies that show that in some hospitals the incidence has decreased, which is good because it really shows you the efficacy of precautions when everybody's implementing them, because during COVID, I'm sure compliance was over 100%, right? So the answer is yes, the studies are few. As an aside, because of COVID, we're seeing a lot more other hospital-acquired infections like pneumonia, for example.
Okay. Now here's an interesting question and I think everybody would be interested in, which is, how do you talk to patients about C. diff? Erica, you've been in this position often now. What do you actually say to patients? How do you deal with this? You know, it's easy to feel like you're a pariah if you have a disease that everybody is trying to keep away from. So how do you talk to patients about it?
So it's as an infectious disease doctor, we have to deal with patients with methicillin-resistant Staph aureus, with COVID, so we deal with that issue quite a bit. And it's the general principle. You tell them it's not your fault that you got it. You were at high risk because you needed antibiotics, and that puts you at high risk. I reassure them about low rates of mortality and morbidity as long as they take their antibiotics, but also inform them there's a chance of recurrence. And then I emphasize to them that they're at risk of putting their loved ones, that when they go back home, at risk of getting C. diff, or if it's MRSA, and to be very, very careful about precautions and hand washing, using a different bathroom when they're at home, etc.
Right.
So education, and reassurance. And that it's not their fault. That's a big one, that it's not their fault.
Yeah. Nicole, do you have anything to add to that from what you've heard at the CDC?
Not really. I mean, that was very well, as an infection preventionist, it really, I always come back to, infectious diseases and C. diff they're equal opportunity employers, right? They'll take anyone. So it really isn't the patient's fault if they get the infection. I could easily get C. diff just as well as they could. So yeah, just reiterating what Dr. D'Agata said.
Yeah. Well, that's a really great place to sort of wrap it up, talking to patients and talking directly about what we need to make them be comfortable and understand what they need to do to help get better. So really, on behalf of the American Society of Nephrology, the American Society of Transplantation, all of our kidney partners and our presenters, let me thank you for joining us today. You'll see that you can claim your CME for this, and you see the instructions here on the sheet. Any other questions or concerns, you can reach us at NTDS on the website for the ASN. Thank you all, and have a really great day.